Good evening. This is Dr. Mark Sokel talking to you about risk adjustment programs, and this will count as 1 point for your incentive bonus in 2018, which should be worth about $800 for the 32 minutes. What do endocrinology, ophthalmology, and podiatry have in common? And the answer, of course, diabetes. So we'll focus a bit on this during the presentation. That's why we lumped you together. So no disrespect to anybody here. All of you have heard me talk about this or have gotten fairly savvy about this, but we wanted to make sure everybody's on the same page for the coming year. So here are our definitions. Risk adjustment factor is a RAF score, which estimates a population's complexity and expected cost to the payer. The payer derives this from and doing adjustments to codes called HCC codes, which ascribes points to high-value diagnoses such as diabetes or cataracts associated with diabetes or gangrene associated with diabetes. These codes must be assessed properly, which I will talk about because it has to do with auditing, and you should be using this for all your patients. And the payer calculation adds up the RAF, the demographics, adjusts it to an average score of 1.0, and then gives physicians or physicians groups money based upon the RAF score. Okay, this is a slide I got at the New England Journal. If you look at the dashed line, that is a unitary line, which means that what the documented is exactly what a coder found doing a post-review. So if you have a risk score of 1 in post-review, you had a risk score of 1. If you have a solid line, you'll see it does not really fall onto the dashed line because doctors code much, much better than others. So for the doctors in St. Paul, Minnesota, their RAF is about 0.92 for a disease complexity of 0.82. That's a point of 1. That could be worth millions of dollars. Conversely, in McAllen, Texas, these doctors do not code intensively and losing at least as much money. Where does Marin fall? Well, we fall closer to McAllen. And all of this, the more, I think it's teal or some kind of blue it is, the more people tended to vote for Trump in the recent election, the better or the more intensive the doctors tend to code. Look at us in the Bay Area, we're kind of a, I don't know, lavender, and we code about -5 to -10% below what we should be coding. RAF is not only a financial game, but it certainly is that, but it levels the playing field, whereby we normalize and can compare our complexity of patient care to folks in Minnesota to folks in Florida. And this also identifies patients who might benefit from case management or outreach, and a substitute for underwriting. As you recall, when we grew up, underwriting was the way insurance companies would go into a market, would decide how sick people are. You know, healthcare workers were underwritten at a higher rate than school teachers, and then write their rates. What happens here is post facto, after the year, Medicare looks at our HCC codes and decide how much money we should be set upwards or downwards. It really isn't paid for a year or two later. So here's how Meritage is done. When we program in 2015, our RAF score was 0.699, recalling that 1.0 is average for Medicare. We therefore lost $2.5 million on 5,000 scanned patients. In 2016, due to your efforts and our efforts, we broke in. And in 2017, we think, with a projected RAF of 0.95, we'll be up 2.5 million, and we'll know for sure in 20, I think. So it is a bit of a guesstimate. Our goal for this year, as we've gotten our skills up, is a RAF of 1.0. And the purpose of this is not only to make money, but to be able to continue to care for high-risk Medicare Advantage patients. And Medicare Advantage patients are a relatively fast-growing segment of the population, and is the only insurance company that monthly rates are very comparable, or maybe a bit lower than Kaiser. So this is really our target audience. So is to take augmented risk and increase it to the actual risk. And that's why I'm doing this WebEx, and that's why we'll be talking more. And beginning of the year, no matter how we've documented the risk in 2017, in 2018, it all goes back to zero. So if you had it in 2017, you don't in 2018. If you amputated toe in 2017, it grows back in 2018 until you deem otherwise. Example of one of my favorite patients named Esther. She's 92, already worth some money. Her risk adjusting diagnoses or conditions as diabetes with other ophthalmic complications, which means that your ophthalmic complications such as cataracts or retinopathy have to be associated with diabetes in your assessment. She has depression because she is depressed, and has funplegia because she needs a lot of help getting out of the wheelchair from her RA. So add these up, we add the demic risk factor, her HCC risk factor. She had normalized RAF score of 2.2, which is very high and is worth probably $1,000. So we get $9,000 for this woman if the codes are documented. If we didn't, we would get probably about $4,000. Switch gears for a minute, and I've gone over this in some of the talks you've seen me, but this is really important. What coders are looking for is how you document. Now, a lot of, not coders, I mean auditors, what they're looking for is for you to mess up. And so you have unclear assessments. They will not code you. They will not give you credit for the work you've done. So what is considered proper coding? You start with a diagnosis, which could be your ICD-10 code with verbiage. And then if it's a new diagnosis, you write your logic, which is what you think that it has a disease. For example, in this one, let's say atherosclerosis on chest X-ray, you say atherosclerosis on chest X-ray, and then your plan, which is monitor or start lipids. If it's a diagnosis, you say the status. Status, stable, plan, continue current management, or something more than that if you like. So there's components. So let's hear diabetes. If it's a new diagnosis, you look for the diabetes code, diabetes type 2. How to come to the diagnosis? Well, the FBS was 129 twice over 3 months, or the A1C was pretty high, over 6.5%. So either of those would qualify. That's logic. So diabetes, noted A1C 7.1%. Plan, we're going to do dietary and exercise counseling, repeat in 3 months, and we'll drug a person if they don't get better. If diabetes is, or depression, let's say, is an existing diagnosis, it's very similar. So if someone's depressed, look at the coding that we'll give you, and we'll see that depression doesn't count as an HCC code, but major minor depression does. If that's appropriate, you document that, and you'll give an evaluative statement. How's the patient doing? PA9 drops from 11 to 7 on Zoloft. What are we going to do? Augment with bupropion. Most of you won't be doing this, maybe the endocrinologist at times for depression, but you will be doing it for, let's say, neuropathy. If you diagnose as neuropathy in your practice in a diabetic, you should refine that code to neuropathy associated with type 2 diabetes and then write your verbiage. Example CKD4, which will certainly occur in the ophthalmology and podiatry charts. You see you made the diagnosis, which is an eGFR less than 30 over 2S. You say what you're going to do. Continue blood pressure control, avoid NSAIDs, obtain renal ultrasound, and if it's established, you give a status report, worst serum creatinine, stop NSAIDs, and retract. The pin of this is to say stable, continue current management, and that's often the case. Okay, diabetes, which is the common denominator amongst all of you, basically is a gold mine. Almost any metabolic or vascular or neuropathic diagnoses links to diabetes and becomes HCC. So any renal disease, if you link it with pretty much the eye diseases, and I only understand retinopathy and cataracts, neuropathy with peripheral vascular disease, with dyslipidemia, as well, leg ulcers, gangrene, and erectile dysfunction. Note if erectile dysfunction and you're diabetic, it's not an HCC code, but if you do, it's worth money. Okay, so some examples. Let's say you're an ophthalmologist and you want to do a surgery on a cataract, and so diabetes, diabetic. Your diagnosis should be this one here: diabetes mellitus with diabetic cataract. Assessment plan, worsening vision in both eyes, scheduled pre-op with PCP. If you have cataract alone and then diabetes, we won't get credit for this. Hyperlipidemia, again, has to be linked. If it's hyperlipidemia at the second diagnosis, it won't be. Our assessment plan is suboptimal LDL, increased Lipitor. And think diabetes with erectile dysfunction. ED alone does not count, but ED with diabetes does. And why is that? Because it costs Medicare more money when they look at claims over the years. So a tip, having done this for 3 or 4 years, I always have a simple diagnosis of type 2 or type 1 diabetes without complications. That I see the patient for the 3-month visit. I don't have to worry about everything and clear records. So I'll have a diagnosis, type 2 diabetes. I'll make an evaluative statement, target at 6.9%. Continue the form and lifestyle. And then we'll add, if I assess them, the complications of neuropathy and ED and hyperlipidemia. Okay, this is a, what do I call this, cheat sheet or coding cheat sheet for endocrine. And these basically summarize 95% based on your practices of the HCC code. And we have endocrine gland disorders, Cushing, hyperparathyroidism, whatever that is on the page. And then for podiatry and endocrine as well, we have peripheral vascular diseases, which you'll be seeing a lot of, osteomyelitis. Again, sheets, all these will be distributed to you if you have them. And most importantly, is document the absence of digits, especially if you've taken them off yourself. So these are just examples of some of the HCC codes. Not until I started doing this did I document amputation, status with amputation of first great toe, assessed wound is clean or good incision, plan, look at you every day. That is worth about $2,000. If you don't do it, we're going to miss that money. Ophthalmology, almost all your HCC codes, unless you have a cancer going to the eye, have to do with diabetes. And here are the codes that are basically HCC that you can kind of look for. Yeah. Okay, maybe I throw that out there because some of you might be treating it, probably mostly endocrines. You have a mild elevated PHQ-9 or on Zoloft and you started it not for neuropathy, that counts as an HCC code. All of you might be seeing alcohol and drug dependency. So if you're doing a pre-op on someone who's going for cataract extraction, if they have had a drinking problem in the past, then they have alcohol dependence in remission, and that's 0.4, about $1,500. Same with active drug dependence. So those are codes that all 3 of you groups might find your way to coding. Of course, the primary should be doing this as well, but better than sorry, and hopefully we all will be doing it. I'll help you do this. Remembering now that at the end of the year, our group after Meritage determines what will get paid for the care of risk patients. And currently, almost 80% of our patients have some form of risk involved. Scans, 5,000 or 6,000 patients. WHA, which is our largest commercial group, all of them are risk patients. And Blue Shield, we have an ACO and also a PPO that we are paid for based upon how we code. For the primary care physicians, we will help them identify which codes are HCC, And we'll also send nurses out, advanced practice clinicians out to the homes to cap codes if the patients can't make it in or the primaries have no interest in doing this. This list, you have just about completed the education WebEx. If any of you are new, like a brush up, or have hired a new partner or younger partner, please contact me or Jess, and we will get you training one-on-one, and we will be sharing coding guides with you if we haven't done so already. So, example of a patient, you can see her exam that she's likely a diabetic. She's likely missing part of her leg, and she's type 2 diabetes. And it looks like it's the right leg, but I'm a specialist, so I probably missed that. And it's debilitated that she needs a 1 to 2 person assisted transfer. She's got cataracts. Her PHQ-9 is 10. These are medications, Norco, which she takes around the clock, Gabapentin, Lantus, Ulog, and sertraline. So I'll be quiet for just a minute, and we'll meditate on this and think in your own minds what HCC code that I've gone over might she have. I'll give you 10 seconds. Oh, and that was enough thinking. Okay, so clearly she has major depressive disorder because she's on Zoloft, and that's a definition of major depression, unless it's for anxiety or neuropathy. Speaking of empathy, she has type 2 diabetes mellitus with neuropathy. Why? Because she's had an amputated leg and she's on gabapentin. She's diabetic cataract, and not separately, a diabetic cataract. Now, you have to believe this. I don't want you to make it up. If you think it's completely unrelated, like she was a ski instructor for 30 years, you know, don't put down diabetes. She has quadriplegia, which is important, I think, for the podiatrist and the endocrinologist especially. Someone so debilitated that they're stuck in a wheelchair without help. Functional quadriplegia is worth $4,000. She has dependence because she's around-the-clock Norco. If we stopped it, no doubt she would have a withdrawal effect. She had acquired absence of the left foot below the knee, which we code every single only once is enough. So her normalized RAF is close to 3, was extraordinarily high. We get an additional $10,000 from the feds for taking this person if we document these codes. So why should we bother about paying attention to this? A, because we're providing care, we're just not getting recognized. B, the way of documentation I outlined should be the way you document for all of your patients. All of the auditors will be looking for this as we move forward since they take pages from the medical notebook. The individual RAF scores that you put together allow us and the case management team to reach out to patients who need extra help. And sometimes you'll find things that you didn't know the patient had. The slide's getting old, but I end this talk with this all the time. This is a trick, so high above the hushed crowd, Rex tried to remain focused. Still didn't shake one nagging thought. He was an old dog, and this was a new trick. Because all you have to do in modern medicine, take consolation perhaps that whatever you do, it's twice as bad for primary care physicians, and whatever help you can give us by identifying the codes, we appreciate, Meritus appreciates, and 85% of the money we get back, that's profit, we turn back to you in terms of incentive bonuses. Thank you for your attention.